All right, I believe we are recording now.
Yeah, it says recording up in
recording. Thank you
Yep.
for telling me. So welcome everyone to our monthly webinar. With every webinar, we're getting better at this. We've got everyone's face on the screen this time. We can all hear each other. So we're cooking with gas. This week we're looking at, I'm just trying to remember off the top of my head because I did cover this one before, established self-directed recovery relationships. I think it was November last year. Did any of you guys attend that?
No.
Rog?
Yeah, I did. I did.
You did, Hector.
Yep. Yeah, I did. Yes.
So that time we had a bit of technical difficulties and we really didn't get through a whole lot of it. So I'll try and keep it, still a bit conversational, but I'm going to aim to get through a little bit more content than I did last time. We'll see how we go. So this is broken up into the different sections of the unit. I can see Linda leaning into it. Are you on a computer or a phone?
Yeah, I am. I'm wondering if I can put the view up. I think I might actually.
Zoom in. If I zoom in like this, does that...
Oh yeah, that's huge.
Oh man.
Oh, it's okay. I've put my computer up.
I think it's not going to be, it's zooming.
Yeah, that's okay. I'll put my computer up to 100%.
No worries. Yeah, cool. And you guys can have a copy of this. So yeah, this section addresses the following criteria. Acknowledge and respect the person as the author, definer, and director of their own recovery and recovery journey. And you'll see some common language and repeated concepts depending on which units you've done, because this whole mental health cert now is all about recovery and the recovery journey, the recovery model, recovery everything. So work in ways that inspire hope for the future, belief in recovery by investing in the person and the relationship, increasing support for the person in their community of choice. So you notice the language there, their choice. They have choice in their life and recovery. Identify and take into account personal values and attitudes regarding recovery, mental health, and illness when planning and implementing all work activities. And demonstrate consideration and respect for the important contribution of the person's other relationships. So we're looking at not just the client and maybe a professional psychologist, but you've got, us usually as a support worker type role, families, friends, everything like that, culture, activities, etc. So what is recovery? Recovery is personal. So that means that for all people, it will look different. It will have a different flavour. It can be a journey for some and a destination for others. So you have something like situational depression. Someone has, maybe they have some sort of a crisis in their life, like maybe they lose their job, they have a loved one die, and a number of things compound to create situational depression. So I'm not talking about normal grief. You can have normal grief, you lose a loved one and there's a grief period. But I'm talking about if there's complicated grief, when there's a complexity to what's going on, or if there's a complexity to what's going on and that sort of creates a depression type situation. And so that might be a thing that has a fairly clear start and end date. But then for others, something like schizophrenia, although they might manage their illness well, recovery isn't going to look like a recovery from the illness entirely, the side effects entirely, even if they may live well for really quite long periods of time. So recovery involves the development of new meaning and purpose in a person's life beyond the effects of the mental illness. So it's about having identity beyond the illness. And, this is the age-old discussion. How useful are the diagnoses? is that helpful or is it counterproductive? Not something kind of in the scope of this unit, but as long as a person doesn't start having their kind of ego identity wrapped up in the diagnosis, then you know, that's kind of like the issue. But if it's a helpful thing, it just helps them understand and helps them find treatment, and you know, presumably that's a good thing. It's person-centered, not illness-centered. So it's not like when you go to the doctor and you've got a particular illness and they're going to give you a drug and it's just about that. Not that a doctor can't be person-centered, but, you know, often it's quite transactional. And, yeah, it is, again, a thing you have and then you recover from it. This is person-centered. And strengths-based, not deficit-based. So it's not about what you haven't. Okay, we've got Desiree. Hello, welcome. Desiree? Awkward silence. He's gone mute. Can you hear me? Just saying hi. Okay, I'll carry on. There he is. He can hear me. Strengths-based, not deficit-based. So, I mean, in a sense, it's self-explanatory, but just to explain it, I think I'm echoing now through someone's mic. If you guys want to keep yourself on mute, or actually I can mute you, unless I need you to talk, and then so we got mute and Desiree, how is it? Mute, there we go. So a deficit-based approach is focusing on the problem, the issue. You have anxiety, you have depression, you cannot do ... And whilst this isn't suggesting any sort of denial, it's about, for our role, because we're not coming with a clinical, psychological kind of thing, it's actually about focusing on the person's strengths. And we're going to talk about strengths-based practice later. But yeah, that's very, very central to this certificate, but to the way the industry is going. So common factors in recovery. Things that are key, things that are important. Hope. So I'm sure we all know that when, especially for something like depression, but whatever illness, it can be quite hope draining, or it can be hard to maintain a sense of hope and belief that there's things to look forward to in the future, that I can get beyond this. Not that I'm necessarily recovered, but that I'm beyond it, that I can have more to me than that. So that's desire accompanied by confident expectation. Oh, this can initially be carried by someone else. Yeah, this is a good point. So we as support workers have a capacity to potentially carry some hope. It's not that we take on the issues of the person, although it can be tempting. It's about us having a vantage that's not in the fog or the cloud that they're living in. So we can potentially see that although they're saying, it's always like this, I'm never going to get better, I'm never going to have friends, I'm always going to be whatever it is, actually, we can actually zoom out and go, well, actually, this person's come a long way. You know, 2, 4, 6 weeks ago, they weren't, you know, they were running late for their appointment with me, they were still in bed when I got there, and now they're up, now they're dressed, showered, whatever it is. And so we can sort of give them those cognitive, concrete evidence, not cognitive, concrete evidence to show them, you know, so carrying hope, and it can be in all manners of ways. Empowerment, a belief in control over one's life, which translates into taking responsibility for their own recovery. Huge lesson for me, thankfully a long time ago now, that if you take responsibility and you carry not just someone's hope, but their pain, their challenge, their issues, and you don't let them fall when they need to fall, and you don't let them have that responsibility, number one, the likelihood they're going to actually be able to genuinely grow and move on is going to be reduced. but also they're not going to take responsibility for the good. So we don't want our clients to become reliant on us. It's about, I mean, it's an overused word, but it's about empowering them. It's about teaching them, educating, mentoring, depending on the role, so that they can actually, so essentially we keep pushing it back to them. So it's in the disability sector, it's, what's the saying? Something about like, if they can do it, let them do it. You know, if you don't use it, you'll lose it. And it's the same principle here, to not get into the habit of actually like, oh, this client has to make 3 phone calls. And I know they've got a lot of anxiety around phone calls, so I'm just going to go and make the phone calls for them. You go, no, maybe what we'll do is this, all right, I'm going to make 2 phone calls for you this week. And your job before next week is to make the 1 call. And, you know, you support them through that. Empower them. Support, it's pretty self-explanatory. Peers, family, and health professionals, you'll often find clients that are very isolated. So that's, you know, that's a big, big contributor to mental illness. It's a bit of a chicken or the egg thing. You know, did the illness come first, and then they lost their supports, or did they have not many supports and then they became unwell? Education, knowledge. So intellectual and experiential knowledge, knowing themselves and knowing, you know, other knowledge that could be useful. So sometimes knowing that we're only able to physiologically experience, say, a panic attack, physiologically that can't go on. The body can't continue to create those chemical responses, the adrenaline release. It's actually quite finite. And so if you're having a panic attack, knowing that actual intellectual information, like, I just need to wait this out and it will pass. And that could also be an experiential knowledge as well, that, oh, this lasted 3 minutes last time. Any questions? Does that make sense? You can always put up your hand and I can unmute you, or you can do it yourself as well. Just jump in if you need to jump in.
Yeah.
Yeah, go on.
Yeah, no, at the moment I don't have any question so far.
You don't? All right, well, jump back on mute then if you don't, just to stop any like feedback loop of background information, background sound. Self-help. So self-help can be quite broad, from self-identification of symptoms to applying coping skills. So, you know, taking it from the abstract, actually applying it to their real life situation, or, you know, researching and like, it's another way of essentially saying taking responsibility. Spirituality. This can be a bit of a controversial one in our society, depending on the worker, depending on the client. I've known workers, or actually had a student some years ago who was atheist and had an issue with the spirituality piece. Well, actually for us as workers, it's not about our views, whether we have spiritual beliefs or not. It's about, you know, so if we have spiritual beliefs and we find them helpful, but our client's not coming from that place, and it's not our place to impose that. But yeah, they can just be a really like the studies have shown, when they look at people with spiritual beliefs, religious or just spirituality, that it makes it's only good for wellness, as long as they're not in a, you know, an abusive kind of religious situation. It just adds. So it's just another tool in our tool bag. So yeah, supporting people in that. I'm thirsty tonight. Employment, meaningful activity, influences a person's sense of self and their confidence. Medication. I had this question from last time I wanted to do again, so you'll have to unmute to respond. But what do you guys see as medication's role in recovery? There's no wrong answers, it's just your own view on it.
Just talking from my place that I work, we have a lot of disability, and a lot of them are medicated for their mental illness, and they don't have a choice because it's a doctor's decision. But they do have PRN, where we try to talk them round and sort of give them positive feelings or calming, just so they...
Want to just explain what PRN is for those that don't know?
They can request a medication that helps them calm down.
So in addition to their regular medication?
Their regular medication, yeah. And we try to talk them, not out of it, but try to keep them in a calm place, maybe suggest removing them from a situation, going to their room, listening to music, anything that may have triggered them into a situation, try to remove it without medication. But they do have certain medications that keeps their condition to a certain level, which we can't take away, unfortunately.
Yeah.
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 So that's what I see it as, but I don't know if that's right.
I was about to ask you why I can't take it away, unfortunately, but that's a rabbit hole. But we'll see what other people have to say about medication first. Hector's off mute. Are you wanting to jump in?
Yeah, I don't have experience, but but I think about medication is about, we have to just check what the doctors or the specialist sent, what kind of medication and what time we should give to the patients, and just let's be careful about that. And also we don't have, we can't give any medication to them.
So you're just saying that, you know, we need to work with the doctors, work collaboratively, or doctor or psychiatrist, I suppose. Yeah.
Yeah. That's it.
Anyone else got? This can be quite a, not controversial, but people have quite passionate and strong views on this topic. What about Saroj or Desiree? What's your views on medication's role in recovery? If you don't have anything to say, that's fine, but just, So, you know, I'm saying that it can be kind of controversial or whatever. To give context, you know, there was a time in my life I knew very little about this, and obviously you guys studying may or may not. I mean, Linda's been exposed, but it's a controversial one because, well, no, it's a difficult one because I think we come into this space, whether it be studying mental health, people studying counselling or psychology, with a level of idealism. We're going to get in here and we're going to love and care for people into perfect psychological health. And then, you know, the reality of the situations can come up. How can I put this? You have to hold the balance there of hope and optimism and enthusiasm for, I believe I can make a difference, I believe I can help people, with to what degree are we managing, or is this person managing their illness and looking to live well rather than to 100% recover. There's people out there that think that depressants are no more than a placebo, that they don't work. Some of that's probably based on misinformation, and some of that is because they don't work for everybody. I can't remember the failure rate, or, you know, but there's a solid percentage of people that it won't work for, or psychiatric, you know, all these ones, because the brain's complicated and the chemicals in the brain are complicated. But medications have, look, I could talk about this all day because I'm quite passionate about it, but medications have a role. and you talk to someone that has found them useful, that was struggling in a big way, that has now found antidepressant or whatever that works for them, you get that sort of first-hand experience hearing that, oh my goodness, I didn't realize how jumbled my thinking was, or oh, I think, you know, so grateful for this, the stability that the medication was able to bring me to then be able to think clearly enough, to then be able to set recovery goals, to then be able to make, take the steps I need to take to get well. And there's a lot of people that just use them for a year, 2, 3 years, work through some issues with a little bit more stability in their emotional world, and then they're able to come off them. We do over-medicate, I think. That's my personal opinion. But that doesn't mean to say that they're not of value. They can sometimes be the missing piece. So I talked about this, the recovery model. It's not about a reduction in symptoms. Obviously, that's a positive thing, but that's not our goal. It's about improved functioning. It's about living well with the illness. It's about finding a sense of meaning within suffering or in spite of it. So, you know, maybe they're not able to reduce their symptoms, but they're able to reframe. They're able to reinterpret. They're able to have a new perspective on what they're living with, what they're experiencing. Yeah, I don't know if you come across that, but I have, even in my own life. You know, you take a different. You ever have one of those days where, you know, you feel like, oh, well, you know, everything's bad. I've got all these issues, I've got all these problems, and then you bump into a friend or you come across a news article of someone who's in an infinitely worse situation, and it kind of just shakes you and says, oh, gives you some perspective, you know. It's not about minimizing people's pain and suffering, like, oh, you know, there's people that are worse, that are, you know, dying of whatever else. No, it's not about invalidating, but sometimes our role can be to help people gain perspective and to get them out of that rut, to help move them out of that rut. So strengths-based approach. What do you guys know about it? I want to hear from a few of you on this. This is probably something you've come across. It comes up in a lot of the assessments. What is a strengths-based approach? While you're thinking, I'm going to fill up my glass. Desiree, Siraj, haven't heard anything from you guys yet. What's a strengths-based approach? Here it is, Desiree.
Sorry, but I was talking before. I didn't notice that I was muted already. It was in regard to the medication thing.
I kind of caught that. Can you get a bit closer to your microphone?
Yeah, I hope.
My voice to you guys is all right, isn't it?
Yeah.
Yeah, cool.
How about now?
I think it's a bit better. I'll turn up volume a bit. Okay, just say it again if you don't mind.
Yeah. I was saying that I was talking before, but I didn't notice that I was muted.
Oh, okay.
That was the point with medication.
I see. I didn't realize, and I obviously didn't see your mouth moving.
So
all good.
Yeah.
Strengths-based approach. What do you think it is, or what do you know it is?
I think it's the way you approach, or the way I think the whole thing of support you give to your client. It's sometimes the more you understand, you put yourself in in your client's role. I can say you understand more. That's
Put yourself in your client's, what was it, sorry?
I said in world or circle.
World, yeah, yeah.
So I think that would be more approachable than than treating or supporting something you don't understand and you don't really know what the person is going through.
Mm-hmm.
That's my point of view.
Mm-hmm. Mm-hmm.
Yeah. So yeah, it's like it's even in everyday life. You may be in something serious and someone can undermine it and say minimize the thing, but with the way you're approaching the person with the full understanding and feeling the same thing that the person is feeling, I think it would be better, with a good positive approach to it.
Mm-hmm.
Yes, and yeah, I don't know if
You're on the right track. I'm going to jump to the second question,
yes,
because I think it might be a better launching pad to help understand this. At least I find that when we reference ourselves, it's can help us understand. So I'm going to put it back to everyone, but feel free to jump in, Desiree, but I didn't want to put you straight away on the spot with this one. If you are seeing yourself as a client, what strengths would you focus on? So I'm looking at you. How would you use a strengths-based approach on yourself? Give us some perspective on the kinds of things that we might look for in a client and emphasize for a client.
First of all, it's always like we are talking about clients here, but it's in everyday life as well, even for someone who's not really suffering with mental health problem. When you are, if I'm a client, I would focus on who really I am as natural,
You'd focus on who you are naturally, did you say? Yeah, and who are you naturally?
I think the more we be positively, positive, you know what I'm saying? Yeah.
Yeah, I want concrete examples.
It's so hard because when you're a client, it's so hard to understand exactly what's going on, 100%. But based on the experience, some situations, there are some clients who can self-regulate, like they can really, they don't need medication to regain their mood or to understand things. So to me, that's what I would put in a first place. Like understand that situations really, like if you are, how can I say this?
I'm going to jump in.
Yes, please. Well, thank you.
I'm going to let you have a little think about who is Desiree, who are you, and what are some of your strengths?
Yeah.
Would you guys like me to give you an example? Or does someone else kind of understand what I'm asking about if you're a client? I think Suraj is talking, no? You have to unmute, Owen. There we go.
In my point of view, its strength is like your personality, showing your personality.
Yep. Yep. So what would be a strength of your personality that if I was a client, if you're my client, that would be a good thing for me to emphasize?
And expressing about yourself, who you are and what can you do and how can you present it.
So what can you do?
I think, can I say something?
Yeah, sure.
Yeah. I think it's about, that you say that the people, they have something. I think they have something like skills, their own abilities or knowledge that they can use to improve in the recovery.
So if you were the client, what sort of things would you think that I should focus on about you? See, you guys aren't used to talking about yourself and what's good about yourselves. And I'm pushing you on it because we need to know ourselves if we're to work with clients. So if I was working with you, Hector, how would I do a strengths-based approach? What are some of your strengths that you would use towards recovery?
Yeah, I don't know. Like my knowledge, the knowledge that I am getting in the studies,
your knowledge and your studies, did you say?
No, just the knowledge that I am getting from the study, from my studies, books.
Yep.
And I think, I don't know, strengths. Yeah, I don't know. Yeah, that I am, how do you say? I forgot the word. But I am a person, no, I don't know, tidy person, something like that.
Yeah. So you've got some knowledge, you've got some ability to tidy up and organize. Yeah.
Yeah, and I think, if, for example, if I am a client, I can, I don't know, like help him or help him like I don't know, example. If his outcome is I don't know, have a good aliment, good food, like be healthy.
Yes.
Yeah, I can help him like if I give a recommendation what kind of food is good. Like try don't eat, I don't know, McDonald's, KFC. To buy some food like vegetables in the supermarket, chicken, and cook, and be tidy. Be also, I don't know, give a recommendation, cook just 3 times per week, and then I'm putting the frozen the food. That kind of help to their outcomes with my knowledge.
So what I'm hearing from you, Hector, is you're saying to me that if you're a client and you're struggling with some sort of mental illness, let's just say it was depression, and I was working with you, I could then focus on the fact that, well, Hector, you might be struggling, you might not have a job, you might not know what you're doing, but you're keeping your house tidy. Even with your depression, you're still getting up. I don't see any dishes on the sink. You're still tidying up. You're still eating well. You have this knowledge. You're eating vegetables, and so it's like, I find those things that are good, that for you might just take for granted and they're small. And instead of you waking up, oh, got no money, I'm a failure, I can't do anything, I'm so, all these stories that, a depressed person tells to themselves. The strength-based approach is actually finding those good things and actually growing them, helping them to grow, basically watering them. Does that make sense?
Yeah.
So, okay, so if I use myself as an example, and I'm pushing you guys on this, as I said, because we're not used to seeing the good in ourselves. But if we can't do this ourselves, how are we going to help see that stuff in our client? You know, for me, strengths-based approach, empathy, care. I think you'd all probably have that. What are you here for studying this? Care about people, care about the well-being of people. For me, it's also knowledge. For me, it's my own, what else? If I was the client.
Communication.
Say it again.
Communication.
Yeah, communication.
Mm-hmm.
And age. I think I've already done a lot, and I've already got through a lot. One thing I've learned about myself is that I have a tenacity. I stick with things. Although I'm actually quite sensitive, and I can get like worn out quite, you know, a little bit quicker than or whatever. I actually have a tenacity that I keep going. I don't give up. I have good supports. This is another one that you can look at. You know, I have a good relationship with my wife. So if I was a client and I was struggling, there'd be a major factor to say, you know, you've got a family that loves you. You've got a relationship with your wife that's positive. You know, I could go on. It depends on my specific situation. I won't put you all on the spot again now, but it's something I really want you guys to think about. Who am I? What are my strengths? What do I have to bring to the world? And use that as a launching pad to start to learn how to see that stuff and pull it out of people. And sometimes it might be a very small thing. It might be something as small as when I call you, you answer the phone. I have other clients that struggle with answering the phone, or, you know, you don't have to break confidentiality, of course, but, you know, like there are people that struggle to answer the phone, and I call you and you answer the phone. You have a dependability and a reliability there. They might think, oh, it's just answering the phone, big deal, you know, but then you kind of build on that. Sorry, Linda, you're going to say something?
Oh, no, I was just going to use an example. We have a lot of behavioural issues where I work, but all my clients, we have 11 clients in wheelchairs with different mental disabilities. And we've got one gentleman at the moment that just being praised for taking the rubbish to the bin in his wheelchair and putting it in and getting a pat on the back and well done changes his day. And it just puts a great start to the day, and just acknowledging that can put him in a good mood for the day. And if you don't, we could have behavioural issues for the rest of the day. And it's just that acknowledgement and praise and all done, even down to a chart we have of chores. And when he sees the ticks appearing on it, his mood just gets better and better throughout the day. But as soon as you ignore him or don't talk to him or move away, and we don't focus on that strength, we have a completely different person on our hands.
Yep.
Yeah.
Brilliant example. Love it. Thanks.
Yeah.
So do you guys feel like you're kind of catching this a bit better? Because it comes up in a lot of your questions, I think. You can just nod, although we just lost one.
There is.
Did you want to say something, Desiree?
Yeah, it's so hard that when you have not booklets, or you haven't started with start with everyone, you know.
Yes.
But, yeah, what I want to say is just to add what Linda said. You know, as support workers, some people can go and work in there thinking that a disabled person is someone you have to do everything for them, or when you are that you're working with supporting someone with mental issue, you have to do everything for them.
Mm-hmm.
But being disabled doesn't mean that they cannot do things. They are really, like, we used to say that they have got their way of doing things, but still can do. So this point, strength-based approach. As Linda said, there are some clients, you go there, you think you are helping by doing everything for them, but really they know their strength. They want to do it. So as a support worker or as you on service of supporting, it's really, really very important to give the person you are supporting time and prompt or encouragement to do their own, yes, because they really can do that. So that's just what I was thinking of.
Good point. Yeah, prompts. Exactly. And it can be hard. Especially the person in the wheelchair. I'm sure Linda's thinking, gosh, I could just grab that stuff and put it in the bin. But, you know, it's like, I can't think of an example now, but I've had it many times. It's like, okay, I've got to let this person do this. And you know, if it's washing the dishes or doing some task, sometimes, or mopping the floor, when you work in disability or something and they're helping out, you might have to go back and do that job again.
Yeah.
It's kind of not the point.
Yeah. We always have a can-do attitude. Even the gentleman, he in his wheelchair will try to sweep and mop. And like you said, we have to go back, and while he's not looking, we'll quickly sweep and mop it again. But in his words, he did the can-do attitude, and he did it.
Yep.
And there's other days when his head's not right and he won't do anything, even feeding himself. He'll say, no, you're paid to do that, and you'll have a bad day. So there is days that unfortunately you don't. Yeah.
All right, move along. This is the second point. So we've got about 35 more minutes. So I'm pushing through. I don't know if we'll get through all of this, but that's okay. Establish the context for a self-directed recovery relationship. That's a mouthful, but it's essentially helping create a context where people can help themselves, where people can direct their own recovery. So it's about us assisting them, not doing for them. This section addresses the following performance criteria. Establish and maintain a safe. I should point out that I'm not covering all of these points here. Your unit and your books cover them all, but I've sort of picked some of the major ones. Establish and maintain a safe, positive working relationship and environment. Identify and address the power dynamics impacting on the relationship. Build a working relationship based on shared understandings. Interact with the person showing warmth, openness, care, and authenticity. Discuss, clarify, and use in all communications the person's preferred language, understandings, analogies, and concepts about their experience. So it's just speaking to them on their own terms, in their own language. Adjust communication strategies to meet cultural preferences, and clarify role expectations and define appropriate relationship guidelines. So we're just going to go through some basic communication / counselling skills. This is something that if you go and study counselling, you study the theory and need to provide evidence of in understanding and comprehending, but for this qualification, you don't need to, test it or anything, but these are very much transferable skills that we need as support workers. If you've got good communication skills, it says counselling skills, but this is just the skills that a counsellor uses. This isn't actually doing counselling. This is the skills you use whilst you're counselling, if that makes sense. So we've got attending. I think this actually goes through them in detail. Yeah, it does. So yeah, I won't explain them all now, but yeah, we've got attending, observing, active listening, reflection, and open and closed questions. So contextual attending. This refers to the environment where the communication will be happening. So is it going to be in someone's home? Is it going to be in an actual facility? And then thinking about the lighting. So this is more if you're meeting with someone one-on-one. If you're like in a community-based support work setting, you're not necessarily going to be concerned about this. But if you're maybe having a bit more of a intentional conversation with the client, maybe you would. But if you're in any other kind of slightly more formal context, you want to think about the lighting. You want to think about, okay, I'm about to talk about something quite personal. Is it private? How's the temperature? How's the housekeeping? So do they need the bathroom? Do they want to drink? That kind of thing. Because all of this contextual attending, so all of the context where you're in will either make the person open up more or shut down more. I know when I go see a doctor or a physio or something and they have water or tea and coffee provided, I already open up a little bit. I feel a bit more comfortable. I feel a bit more, and if the lighting's good and it's clean and orderly, that's what this stuff's talking about. Then physical attending. Now this is something that you would do specifically in a counselling context, but do it all the time with clients. I'm working in youth work at the moment. I have highly volatile clients at times. My physical attending, my physical presence and the way I hold myself can be the difference between a client getting angry and aggressive or remaining calm. So it's about having the appropriate posture. It's about maintaining the right space physically from the person. You don't want to get too close. You don't want to be so far away that they'll feel like you're engaged. Squaring off is a specific counselling technique. It's to do with when you're, like if you're sitting with a client, you don't want to sit directly square right in front of them, but almost like you just sit slightly, I don't know. You want to sit in a way, I can't show you, so it's a bit difficult to explain it, but you want to sit in a way that shows you're present without being too intimidating. If you're interested or you're wanting to show you're particularly engaged, it's that leaning forward, which probably works better when you're not on a webcam. Maintaining appropriate distance, which we talked about, and good eye contact. So you don't want to be looking off or looking at your notes or overly, staring at them, making an assessment, how comfortable they are with communication. They might find too much eye contact intimidating, so you might want to adjust depending on the person. Especially for people with autism, they often struggle with the eye contact, so then it's important to keep that in mind. Then we've got psychological attending. So this is about being present psychologically, not being distracted. So it's about, I'm saying don't be distracted by your notes, but don't be distracted also by what else you've got to do or all the other tasks you've got to do. Make sure you're organised, make sure you're on time, make sure you're there with enough time to be present. I've had that before, rushing to a shift and you haven't closed in your own mind the book on what you were doing before you got there, and you're a bit flustered because you got caught in the traffic, and then you're not as present. It's even the same with these for me, doing the webinar, try and get down here early. So I'm present, so I'm not going to get these tech difficulties that throws me off. So all that sort of stuff. Have phone and computer silence. I think that's obvious. And then look after yourself. Hydration, well rested. If you're needing to go to the toilet or you haven't had your lunch and you're getting a bit, you're not got clear thinking, then that's going to affect in your capacity to be pregnant. Oh, and then it says, deal with your own stuff. So don't bring your baggage to work or the issues of the day to work. And usually, not always, but usually there'll be actually, what do they call it? Having a blank. Most organisations have a program in place where you can actually access a psychologist if you need to talk about work stresses or other. What's it called? Linda's putting up her hand.
Oh, sorry. Yeah, we do in our facility. We actually have 3 free sessions to a psychologist if you need it. Yeah.
Yeah, we have it too, but I'm just totally forgetting the name of it. There's a name for it anyway, but
yeah.
So that's a thing that exists. And that's confidential. They don't share that stuff with your coordinator. Observing. It can be non-verbal or verbal. They reckon about 70% of communication is non-verbal. Let that sink in. You can be saying, I'm here, I care about you, I want the best for you, but the tone of voice and the body language, as I'm sort of doing now, it's like, this guy's in a hurry and he wants to go. I don't really think he means what he's saying. Just one to be very aware of, and something that can be affected dependent on how tired you are. Maybe you're impatient with the client. Maybe you haven't. It can be a difficult job being a support worker or a mental health worker or whatever, you know. We're not always going to be freshest, most optimistic and that kind of thing. It's really important to be focusing on our non-verbals because clients will read it. Sadly, people with mental health issues, you know, they've usually experienced a lot of rejection in their life, a lot of pain, a lot of loss. If you don't want to be there, no matter what you're saying, they'll pick up on your non-verbals. With them, when they're communicating, look out for discrepancies with what's being said. So that's essentially what I'm talking about, but on the flip side, noticing if their non-verbals match up with the words they're saying. And yeah, be aware of overt and inferred communication, which is a similar. What are they saying directly and what are they indicating indirectly? So yeah, and some observational cues might be blushing or blinking or eye movement or laughing or fidgeting, someone that can't sit still, someone that's looking around, someone that's breathing heavily. These are all, I mean, we all know this stuff, but it's about getting better at it. We can always improve on these observations. And then active listening. So active listening is one sometimes people don't seem to understand because they think, well, it's just listening. Well, the thing with active listening is it's what we've already talked about. It's the psychological attending. It's all these things that come together to have us actively listening. So it's paying full attention, putting our thoughts aside and listening to the body language as well as the person's words, and as best as we can suspend our judgments. Or as my counselling lecture used to say, remain curious, which I loved. You know, they're saying this, they're doing this, not, oh, they're this and making a judgment of that. I wonder what that means. I wonder why they're doing that. I wonder why they're saying that. And remaining curious, because there's always more to the story than we know at that moment. And I've said this already, don't get distracted by your environment and don't think about how you're going to respond while the person is talking. You can respond to a person. You can take a few minutes to pause before responding. And I find especially in like a support work context, say a community, like you're working in a house or something with different clients, you can go write some case notes or go do some paperwork, give you a few minutes just to think and work out how you want to talk. Or sometimes I, you know, process with my colleague, how are we going to talk about this? How are we going to approach the situation? Any questions with any of those? I'm guessing some of you, this is not new stuff. So reflection. I've had a few people on the assessments, not you guys necessarily, but a few people not grasp this stuff. So this is a good one to take note of, reflection. So reflection is when you reflect back either the meaning or what you've heard from someone. And there's, yeah, so there's the reflection of meaning and there's a reflection of feeling. So they're distinctly different things. So a reflection of meaning, the example here is, life is just not fair. The client might say, oh, life is just not fair. The reflection that you might give them would be, so there's a lot of injustice in your world. So it's a checking in and flipping it back in slightly different words to see if you've heard what they've said, for one, and then and then they can correct you. And if you have heard what they said, it gives them a sense of validation. It gives you a sense of, you probably have people in your own life that do this naturally. I've got a few friends who are very, very good at doing this. They don't just assume what you mean. They actually check in and, oh, so what you're saying, Dan, is that. So that's the reflection of meaning. Now, the reflection of feeling is that little bit different. So we're not talking about, it's not someone sharing feelings and then you reflect back the meaning that you're seeing behind that. So they might be sharing how they're scared of their father and they're angry about it, and it makes them angry and unhappy and emotional. You don't reflect back, you know, do you I don't know if it's a good example, you know, do you think that your father was ... and switch into like a thinking, logical meaning thing. It's about hearing the emotions, whether they say it specifically. So they might say, I am angry, but they may also exhibit through the 70% communication, the non-verbals, that, you know, they might have their fists together. Like I have a client actually at the moment who, he always puts his fists like this. So we're starting to actually, when he's starting to get angry, starting to say, do you see, you know, you've got your fists clenched, you see that, are you angry? You seem to be angry. And so reflecting back to them, helping raise that level of self-awareness. But yeah, so a reflection of feeling might be they're saying, oh, I'm angry, my father, ... he's always like this, and say, oh, so you're feeling angry that you've been treated this way by your father, and you feel that it's not fair, or something like that. So this is in the realm of a counselling thing, in terms of, like, it probably sounds like I'm talking in a counselling context, but this is stuff that's totally relevant to support work. Not that we're counselling and we're trying to fix the problems or trying to use some special counselling technique that we saw in Dr. Phil last week or whatever it is, but it's just fine-tuning our communication skills. And Linda's example earlier was brilliant, even just the affirming someone's strengths, what it can do. You just reflect back to someone what you've heard them say. It can be really powerful, because most people in their life aren't heard. They're not used to having someone listen to them, often fighting. You know, we're all sort of fighting to be heard. We're not listening to one another. Open and closed questions. I won't open this up for you guys. I'll just go through this part. I don't think there's a need to tonight, but I'm just going to, open questions. This comes up in at least one of the assignments. This is just looking at open and closed questions. So open questions are questions which, when you ask the question, it causes the person to give a longer response, a sentence or sentences response. A closed question, as you might guess, is short responses. So example would be of a closed question: are you hot? Are you cold? You can even say, like, would you like coffee or tea? Very short, one-word answers, often yes or no. Examples of open questions are things like, could you please tell me about your family growing up? Could you please, it could be anything, could you please tell me more about that? Or What was that like for you? Or how have you been going since we last met? So they're open questions. So they're questions that are encouraging more dialogue. And we go through this because it's good to consciously understand this, because it's another technique in your disposal. You know, I've had situations where I need to get information from a client, but I don't want to cause a whole big interaction at that time. Well, I'm going to go with closed questions. And on the flip side, you've got a client that doesn't talk and doesn't open up much, and they're not natural. It's like talking to a teenager, you know. It doesn't matter what you ask them, you're still getting short answers. Then you want to then go, all right, I'm going to try and use some more open questions to try and get dialogue going, so that you're not carrying all the weight and responsibility for the conversation. Otherwise, it can feel like an interrogation, you know, 101 questions, that kind of thing. We've got about another 15 minutes here. I just want to check how many slides I've got here. So, okay, I've almost finished this section. Minimal encourages. So minimal encourages are just well-placed encourages, little words that aim to not interrupt the person, but keep it going. So things such as, I see, I'm not sure I understand. Oh, that must have been difficult. It can be non-verbal. I actually do a lot of non-verbal minimal encourages. It's that attending, it's being present. It's, oh yes, I see. Oh, that must have been hard. And so that can be a real, almost invisible tool when working with clients that they don't see you using, that can really keep the momentum of the conversation going and make them feel heard. So yeah, the idea is to make the person feel heard and encourage them to keep sharing, potentially to even go deeper. And to be honest, if you're good at this, you might have the opposite problem. You might have people that just keep sharing, and it's you know, like you want to keep it, not to turn into them trying to look to you for a therapy session, because we're there to support them. So often, it depends on the client, but often if you're good at this sort of thing, the clients will actually open up, and it will, you know, you're not going to have any problem with them saying too much. You might be wanting to use some closed questions to even wind things back a bit. Any questions there? I'm doing a lot of talking tonight, I know. All good?
Yeah, all good.
All good. So this is funny. I thought we had the, oh yes, that was oh yeah, so this is 2.1. Where have I put it now? This one. So this is establish and maintain a safe, positive working relationship and environment. So a person's home is often the place they feel most at ease. So if we're meeting in a person's home, it's not an option. Sorry, if meeting in a person's home is not an option, and we've sort of talked about this a little bit, finding somewhere that's private, clean and comfortable is a good place to meet them. This is contextual if you're meeting up with a client to specifically talk about something. Obviously, if you just, once again, community-based, it's a little bit different. It's a bit tricky with some of this because as a support worker, you can find yourself in so many different contexts. I mean, the places I found myself. Go on, Linda. I'll unmute you.
Okay, thank you. I know I seem to talking.
No, go for it.
Because we have 11 clients, it's really hard for them to find a safe place to talk because they have a communal house. A lot of them were asked to go for a walk. And as they're walking around the block, they'll say, can I talk to you about something?
Yeah.
Or we have a McDonald's nearby and they'll ask, can we go for coffee? And they feel being out of the house is where they can say something without a carer, another client, without the team leader, anybody like that. So they can actually say something. To them, they're saying it off the books, but really not. So, it's just having that bit of time. I think for them, it's fighting for time because there's 11 of them.
Yes.
So having that walk around the block, it's amazing what you can get out of a client. Yeah.
Yeah, and now you're sharing about that brings to mind my current client. There's two of us working with him, and not always, but mostly, he likes the female worker that's a slightly more nurturing thing, I think, and he has a close relationship with his mother to do the bedtime routine or the last part of it, and that'll often be the time that he'll open up, and the last bit when he's in bed and he's comfortable under his blankets.
Yeah, 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 exactly. Yep.
Yep. So yeah, the more it needs the client, the better outcomes that are achieved. Power dynamics is an interesting one. We want clients to feel in control of their own healthcare. We want clients to feel heard, and we want clients to feel like an equal partner. And yet, as you can see from the picture, there's an inherent power imbalance. What do you guys think about that? Are you guys something you've given thought to? How do we have a partnership, a collaborative relationship with a client when there's by default a built-in power imbalance where the paid worker and the quote-unquote client? And the room is silent. Here he is, Desiree.
Yeah, yeah. I will just talk in the context of this with my experience. I sometimes work with someone who really can manage money than I can, or who you give lists, like a shopping list. They go shopping. I'm really not good with shopping, even though. So I was amazed that I had one. We went shopping, and the trolley was half full, and she knew everywhere to go to find article, and she paid on the counter by herself. And till now, I thank her that. It's like me, I did, but really she did 80% of this work, everything that I could do. And if you don't give the chance to that person, really you will never understand how capable or how really skilled this person can be. So that's what I think I understand from this.
Yeah, well, you've kind of covered two things. That's a strengths-based approach that you're using there. You're picking up on her strength and you're emphasizing that. But what I'm assuming, and you tell me if I'm right, what I'm assuming you're also communicating through that story is that you're leveling the playing field, but because you're letting her be the expert in an area, even though ultimately you're still there helping. Yes. You're letting her be the expert, and you kind of maybe even letting her know, oh, you're really good at this. I'm not so good at this. I need you here to do this job.
Exactly. Yes.
It's a beautiful example. Yeah.
I put her first and me behind. So I said, okay, I will follow you. Sometimes you show that you know, but in this case, really, I didn't know much about shopping, but I gave her the power. Like, take control of this. And really, she didn't let me down. She did everything, So, yeah.
It's a great example. Linda, you unmuted yourself.
Yes, we actually have a lot of empowerment for our clients. Each month we have a staff meeting. Before the staff meeting, the clients put forward the things they want telling to the staff. Mm-hmm. And discussing whether it be attitudes, procedure, what we bought with their money, what we're doing with their money, and bills. And then we have a staff meeting, and that's brought forward, and also we discuss other matters. Mm-hmm. And then after our meeting, they have a client meeting and they discuss the responses. So with our clients, they're sort of in control. We've even had somebody have to leave because the clients didn't want that person there anymore. So with this, they actually are in control of their own house.
Yep.
And even though they don't have full power, they do have a lot to say, and then we have to give reasons why. So
yeah, and it's the same thing. You're giving over power.
Yeah.
Because obviously, ultimately, there's capacity to take that power from them.
Yeah.
But that choice to give them the power. Yeah.
That's right. Yeah, because they a lot of the comments is it's our money and this is what we're paying for, and we need to get what we're paying for. So they're in control.
I suppose that's a change for the NDIS as well, isn't it? It changes
very much so.
dynamic. Yeah, yeah.
And all 11 of them all having separate NDIS plans.
Yeah, wow.
Yeah.
Great new world.
Yes, definitely.
I'm going to go to the next slides because I think there's more on this power dynamics stuff rather than me just making it up and then saying what I've already written down. Yeah, so this is what you've said. Some ways a client may feel empowered is liaising with them. Empowered in liaising with treatment providers. Oh, yeah, this is about liaising with treatment providers. Bringing a support person with them. So when they go to an appointment, actually, I had a student come the other day who has a worker, and so their worker came to support them, but they were, you know, quote unquote, in charge of that appointment with me, looking at stuff to do with their study. Remembering that they always have a choice to see an alternative. That's what you're saying, Linda, essentially. I don't want this person to be working here anymore. Especially with adults, this is a thing. You know, we have a lot of young people that try and get workers moved. And if there's a genuine issue, for sure, but sometimes they'll threaten that. They can't just willy-nilly change people, but definitely if they're an adult and they're in charge of their own funding through NDIS, helping them do their own research so that they, make sure that they're getting the best services is another way to lessen that power dynamic or power imbalance because they're fully informed. And then, just helping them to ask questions and seek clarification about the service they're receiving. So even in youth work, I often, we tell them, if you've got an issue with it, because they're threatened, I'm going to get you removed. And actually, we always say, you're allowed to talk to the social worker. You're allowed to, if you have concerns, you're allowed to raise it. Here's their number. We need to give them access to a way of it. Usually they don't do that because usually there's not a genuine issue. They're just trying to manipulate. But there are exceptions, definitely, where clients have and can talk to the social worker and have this is in youth work, have the worker removed. Now, we've got 5 minutes left, so I reckon I'm going to stop here and just open it up with you guys, last few minutes, if there's any. So what I'm going to do first, I'm going to say, is there any questions about the content for tonight? And we'll do that, and then I'll stop the recording, and then if there's any other few questions, then we can do that as well. And maybe there's no questions, but and you'll get a copy of this slide. I think I've done about, I've got through about half of it, a bit more than half. So any questions or thoughts that have come up?
Oh, now you've completely. Now
That's why I had a small picture. That's a change, isn't it? I thought that might have been the reason.
Yeah. Did you just say that all those other slides down the side, we get the rest of those, do we? So we've just...
You do?
Yeah.
Have they been sent to you guys previously?
I think we got one of the other week, but I never opened it.
Okay. I thought it had got sent there. Yeah, I'll give them to you. I don't know. I'm still working this out. Like, do I put more in there that you... Because I've got... this slide I was using, I've shrunk. because I used to teach this for a whole day. So, you know, how much information, I give you stuff that I haven't actually taught through, but you can read it for yourself. I figure there's no harm in doing that, as long as people don't get anxious that I didn't cover the entire PowerPoint. Yeah.
There's so much you can do in an hour and a half.
Say it again.
And there's only so much you can do in an hour and a half.
Yeah, there is, and I'm balancing content with input.
Yeah.
I figure I'll keep doing it and we'll work it out as we go along what's good. Maybe some weeks we do more talking. Like I had a 30-minute activity that I took out for this one tonight. That would have taken a lot of our time, but maybe next time I'll put one of those in. So
yeah,
as long as we keep doing it, then I think that, you know, it'll you get that benefit. And it's not a big commitment, which is good. So
yeah.
Any other questions or thoughts?